on Mother's Day at 4 o'clock, I'll be giving, the last review. And hopefully I can help make you understand some things and present it in a different manner that can help you understand it more.
You
So
said at 4?
4 o'clock on Sunday, same Zoom. And I'll be going over the same study guide, but I explain things differently than another professor, so maybe it will help you in the long run. You do have a discussion question, and of course, your NCLEX questions. Some of the NCLEX questions last week, the last one that we did have pediatric developmental stages. So some of you had to return them back. If you don't turn me in the right ones, I'm going to say, hey, you didn't do this or that, or I don't see pediatrics. I'll give you a 0. Just please return it back in by that following Sunday and I'll give you credit for it. I know sometimes you might submit things wrong and I get it. So I give you that opportunity to be able to do that because I want to give you a chance. So let's go ahead and
Yes, sir.
start this week. So we're
Yes,
going to
sir.
be, yes,
Can you post some math practice on Canvas?
sure.
Thank you.
Absolutely. Absolutely. I have lots
Okay.
of stuff for y'all. Absolutely.
All right.
So this week we'll do chapter 23, which is sensory neurological, and 24, muscular skeletal. So, and we know this is the last week that's going to be on the exam. Yes, Michelle.
I just wanted to know. Okay, so with the questions, with the pediatric questions, you want us to redo them and submit them?
If you got a 0, and I put in the comments, please redo them, send them back in, and I'll give you a grade. Okay?
Okay, because I couldn't get to the 50 questions. I think that's what the problem was when I went into my pediatrics, but I think you
Okay,
guys.
it's not pediatrics. There's a growth and
Oh,
development one above it. And you click infants, toddlers, preschoolers, school age, adolescents, and you'll have more than 50.
okay, because I'm like,
That's
why?
always the confusion.
Okay, I'll
All right?
redo them. Yes,
It's okay.
ma'am.
Send them in and we'll take care of it. So let's go on with our PowerPoints. Again, during any of this, you're not understanding it, just stop me. I'll explain it and we'll keep going. So we're going to start out with chapter 23, sensory and neurological. We always put these up to tell you what you need to take from this chapter. So newborns, we know their ears when they're born, and as they're a little bit older, they're shorter, straighter, and more open. And what does that do? Well, it creates more incidents of mucus going up in them and creating ear infections. It's because of the way that they are. Eustachian tubes keep us balanced, right? It's the ventilation, it protects, and then it drains if there's stuff in there so that it doesn't get clogged. But many times mucus will get in there and it will. Now, there's 2 types of ear infections. One that we call the swimmer's ear, and one we call the otitis media, or the middle ear. Well, the otitis media is just the outside canal gets an infection in it. And we only treat that with usually just topical antibiotics. If it's due to something that's in there, we'll irrigate it to get it out. And usually we'll warm up some saline, put like a little thin catheter, put it up into the ear with a syringe, and just gently flush it. And actually, the kids usually do pretty well with it. One of the things they say otitis externa is when it's swimming, and it's swimming in, they say, water that's dirty and not cleaning your ear when you're done. I don't know if that's necessarily true, but it's one of the things. Now, otitis media, this is when the inside of the ear gets clogged with an infection, and it is a bacteria. Well, think about the oral pharynx. You always have staph, even if you're not sick. Your oral pharynx is always covered with it. Well, when it goes up into the ear, now it becomes a problem. and it becomes swelling in there, and it's really, really painful. So, how do we treat otitis media? Well, if you get a child in, tell them their ear is hurting, and they'll be holding it, and the little kids they'll point which ear hurts. They'll even go around the corner, go into the other ear with their hands. And it's even 2, 3-year-olds will show you. Give them something for pain. What do we give for mild to moderate pain? Acetaminophen, and it works, okay? So give it to them. Once we start the antibiotics, 2 to 3 days, it should be okay and feeling better. And again, what does the eustachian tube do? It tries to protect the ear to drain it, but it does get clogged, and that's when the infection occurs. And it's also that equalize, and it's also with the balance. Now, speech and hearing go hand in hand. If you can't hear, how can you pronunciate words, right? So whenever you have a speech issue, always think it could be the ear. I'm not hearing right. What are the types of hearing loss that we see? Well, sometimes the sound doesn't get to the middle ear. Sometimes the nerve, the auditory nerve or structures, there's damage, so it doesn't put that sound in there. Or it could be a combination of both of these things. Now, how would you know a kid was having hearing problems? Well, even infants, we know that we do on all children being sent home from the hospital today get hearing tests. So hopefully we'll know by then. But sometimes a little bit later, you'll be talking to the child and they're not responding, or you clap your hands behind them. They don't hear you. Those are clues. Also, it's the speech. They're not talking right clearly. The first thing you're going to do is evaluate hearing. So, one of the things about having children who don't hear well, these are some things that we need to do. Get down on the level of that child, be face to face, have their eyes look at you, and talk in clear tones. And don't try to over exaggerate words. Talk normally, quietly, short sentences. And of course, making sure they understand as they go. So you have a 2-year-old boy scheduled for a myringotomy, which means a tube put in the ear. How should the nurse explain the surgical intervention and its indications on the child's parents? What instructions should the nurse provide the patient's parents before discharge?
Not to swim.
Well, you got to keep it dry, right? Not just swimming, but keep it dry. Even showers and bathtubs, you got to make sure. I just had a tube put in last month in my right ear. I'm having chronic with my sinus and my rheumatoid arthritis. I'm always fighting it. So I had one put into the right ear to help keep it draining for me. Now, it shouldn't hurt afterwards, but you keep it clean and dry. And if they do have pain, it's just as simple as just giving them some acetaminophen, and it works. There shouldn't be anything more than that. So mostly it is the dry. So the eyes start to form really early at 4 weeks in the embryo. Now, when they're born, they don't see. They don't see colors. They see like blur. That's why, and they don't see any depth perception. Both eyes work separately. They don't work together yet, okay? That's about 9 months old, where they put the eyes and work them together. They don't cry until up to 3 months of age. You have little infants, they're crying. You don't really see the tears. You see all of the quivering chin, the eyes shut, but you really don't see them with the tears coming out. And it's because of who they are. They don't have them yet. Dyslexia. When we have a child who's switching all of the letters around, okay, there's some, in their brain, when they see things, they manipulate letters and what around. What is that treatment? It's just getting with a practitioner, getting with a speech pathologist, which also works on the reading part too, and making the brain think differently. Dyslexia can go off into childhood and adolescent and adulthood. And there's many adults today that still have dyslexia because they didn't want to tell anybody that they couldn't see that thing, or they were seeing things backwards all the time. Now, we all know that you can wear glasses for many things. For me, I can't see near, so I am farsighted. I can see across the room a fly, flying around, but in front of me, I can't see. It's very blurry. That's called hyperopia or farsighted. Nearsighted is when you can't see far. That's when you wear your glasses to go driving, and it's called myopia. So those are two terminologies. Children get problems, and it's with the muscles in their eyes. Strabismus is when their eyes just cross. They can't, coordinate their eyes together, and they go in different directions. It's also called cross-eyed strabismus. Amblyopia. You have one eye that looks at you really well, and one that sort of like fades off to the side, up or down. The muscle is weak. How do you treat that one? Well, that one will take and put a patch over the good eye and make that weak eye make the muscle work. And the eyes will come back together. Usually it's like you put it on twice a day for, 2 hours, take it off, and that strengthens the eyes. And then nystagmus is just this little twitching, the eye movements backwards, upwards, or going around. So strabismus, cross-eyed, amblyopia is your lazy eye, and nystagmus is that jerk. So as I said, amblyopia, this is the one that you have that weak eye. The big thing is to put on that patch, make it work. If it ends up taking longer than that, they might put on glasses or contact lenses, and that might help again with that. Again, that's strabismus. This is again where the eyes don't work same together. And again, it could be muscles and making them work and trying to strengthen them, unless it has something to do with a central nervous system problem. So eye strain, I think we all have it, right? All students, eye strain, computers, reading books. What do you see? Well, your eyes are inflamed. They, are aching, burning. They're dripping, right? You get headaches because your eyes are straining really hard. And it's hard to see things. And that's because of using your eyes and straining. Now, if it's because you're squinting, you need glasses, that's how we can correct it, right? I think this is one thing that every kid has at least once in their lifetime, conjunctivitis. It's an infection, usually staph, into the eyes, and it creates swollen red and that goopy, especially in the morning. We could call it pink eye. How do we treat conjunctivitis? Well, we're going to take and with a warm washcloth or compress, we're going to wipe off the crust or the goop out of the eye from this inside to the outside. And we're not going to change the cloth between one eye or the other. Even if they both have it, don't do it. One eye, the other eye. And then their antibiotic eye drops. Now, sometimes the doctor will order ointment. You need to tell your child, even adults, when we put an ointment, all of a sudden you're going to see cloudy, right? The ointment will cover the eye, and that could be really scary for a young child. So tell them as soon as it warms up in your eye, then you're going to see okay. It's the medicine. It means it's working. So we know what conjunctivitis is: itching, burning, edema. And, that kid is just distracted on that. I tell parents, one of the things I've always taught them, when they go home and they're treating their child, when they wake up in the morning to change their pillowcases. Because if they go back the next night on the same pillowcase, guess what? They're just resharing those germs again. So again, keeping the environment clean. Now, hyphema is a little bit of blood. It's an injury, and you're going to see that red, dark red, bright red sort of spot in the eye. And the treatment is just keeping the head of the bed elevated, decreases the pressure in the eye, and then we can give medications, and they'll give them to usually work with the pupil and constrict and try to get that blood taken away. Now, retinoblastoma is when you have a tumor in the retina. Ever go outside at night, it's dark, and you have a little light on, and you look and you can see cat's eyes and dogs and animals in the distance, and you see that white shine? That's what this eye looks like. It's another other name, we call it a cat's eye reflex, because in the dark and you have a little light, those cat's eyes will shine that white stuff. It is a tumor, and it does. First, we'll see that the pupil doesn't react. We're going to see that white glow, and then, of course, the loss of vision, etc. It gets to pain, and it's actually the whole eye needs to be removed. So, nervous system controls everything, right? Whatever you do, whatever you think, whatever you move has to come that your brain is moving it. It transmits all the messages everywhere, and it gets that memory working, right? We know that most neurological disabilities are due to the brain wasn't formed correctly, or there was an injury, or what about meningitis, right? Infections can damage the brain. Now, an altered level of consciousness. What did it do from? Well, most of the time, an altered level of consciousness is due to things like hypoxia. It could be due to falls and whatnot. But this is other stuff that we're talking about. It's not a fall that you fell down and then you're not knowing where you are. These are things that happen physiologic to you, as in your blood pressure drops, or you have a rise of CO2. You have too much CO2, it does cause constriction in your brain, and it causes less oxygen, and it can cause an altered level of consciousness. Fever. We know fever burns oxygen. So with the fever, you could, especially high fevers, have that. They're sort of delirious, right? Drugs, sedatives, anti-epileptics. You take a sedative, something for pain, it numbs your brain. You take something for seizures, and that medication for seizures numbs your brain so it won't spark to have a seizure, right? And the other thing is that increased intracranial pressure. Swelling in the brain can cause blood not get around, therefore altered level state of consciousness. When you hear of Reye syndrome, what do you think about? Take an aspirin, right? No child should routinely be given aspirin for a fever. There's only one condition that we will recommend aspirin to, and that's in the cardiac chapter, and it's called Kawasaki. So Reye syndrome, it's something to do with aspirin, but also you've had a cold too, like influenza, a viral cold, and that causes this metabolic problem, and it's Reye syndrome, and it causes really a child to be very sick. So again, no aspirin for children. Now, one of the biggest things that causes problems with children is infections that aren't treated. And then it goes to overwhelming sepsis, which means it gets into the blood and it gets into the organs, etc. And it goes everywhere. And it could cause shock and death because the body, especially young children, don't like infection. They want it out as soon as it can be. They can't fight with it. Even adults that, are already worn and torn and, weak, it can also cause, overwhelming sepsis and death. Meningitis, we have two types. We have viral, which we treat with acetaminophen, ibuprofen, breast fluids. Bacterial meningitis, and the symptoms are the same. Bacterial, we're going to be giving them antibiotics. And the antibiotic that we use are for the staph, like you might even go home things like augmentin, right? Or sometimes they put you on two different types. How do we find out you have meningitis? And if it's bacterial or if it's viral? We do a spinal tap, right? And the spinal tap will come back. Does it have white cells in it? Has white cells, it's a bacteria. Because remember, even CBCs, we see elevated white count, we know it's a bacteria. And if you have just a regular white count, even though you have a fever, it's viral. That's how you tell differences. So any inflammation on the brain is called encephalitis. And this is extra pressure on the head, if you can imagine. So what are you going to see? Well, a headache. That's the big thing that you're going to see. But it gets more and more if we don't release that swelling in there, and it can lead to coma and convulsions. You might initially, before that, see that fever, cramps, abdominal pain, any swelling in the head, always headache, vomiting, headache, nausea, vomiting, those things. And it's the brain, so maybe you're going to have, the neck stiffness and stuff like meningitis, muscle problems. And, it's in the head. The eyes can also have, abnormal movements. Brain tumors. So again, we're talking about the head. We're talking about something growing in there. And brain tumors are small that can grow big, and they grow or big all different times. Some grow fast and some grow slow. Now, how do we know that they have a headache, have a brain tumor? Well, usually again, increased pressure in the head, headache, vomiting. Sometimes even mobility, you're falling over. Again, pressure in the brain depends on where it is and how big it is, right? So you have a child having trouble ambulating, has a headache, and is vomiting. That's your clinical presentation. We're going to be doing a lab test. I want to do a CBC. What is that white count, right? See if maybe it's a meningitis. And then we're going to go and do a head CAT scan. We're going to do an MRI and, of course, an EEG if we're seeing any sort of convulsive type of activity on that child. Treatment is usually radiation first, depending on the size of the child. Real tiny kids, they'll go in and just remove it and do the chemo, or do chemo and remove it. But we try to shrink it and then get it out. Now, kids actually do pretty good removing brain tumors. So types of seizures. I think the one that we've heard the most about is febrile seizures. My first grandson had a febrile seizure, and he had one, just one, but it was enough to have mom with a thermometer, Tylenol, Motrin in her purse at all times because she was so afraid by it. And what that fever is, once you have a fever, usually you're not going to have a seizure. Even high fevers, I've seen 106, no seizures. It's when it goes from a normal temperature, 20 minutes later, it's 101. You're like, that rate of rise cause that febrile seizure. We know there's epilepsy, which there's some sort of disconnect in the brain, and I call it backfires, and it creates some sort of irregular movements or even blank stares, et cetera, et cetera. There's different sort of seizures. So there's generalized. That means tonic-clonic. That means arms and legs are going, right? They usually foam at the mouth. They can be incontinent. They loss of consciousness. That is the one that we used to call grand mal seizures. Partial could be maybe one eye twitches, or maybe a blank stare, or maybe one side, not the other side. So there are different levels of seizures. So when we're having seizures, number one is figuring out what type of seizures we have. And then we're going to be looking at, again, the CT, the MRI, the EEG, and then, of course, looking for anything that they could have ingested. You know, kids put everything in their mouth, and some of these things can cause seizures. So we always rule out those sort of poisoning things. And of course, electrolytes. You know, the body and the mechanics and the movement are calcium and magnesium and potassium, right? All your intracellular, extracellular sort of electrolytes. So something we look at. The type of medicine is usually the type of seizures or have that we're going to be given. And we usually start with one and then we add on as we go. There are some people who swears that diet changes. They're saying low gluten diets or low this diet, you know, can help. Sometimes that works, you know, and it is a parent's choice to say, all right, I don't want it on those medicines anymore. Let me see if I can change it by diet. And I've read a lot of information on it, some really good stuff. So a 3-year-old is a new patient with seizure disorder. What type of seizures might the child be experiencing? What are the 3 types of seizures I said? Number 1,
Fibro something. I forget.
febrile. Yes.
Febrile,
Yeah.
The other one,
epilepsy,
grand mal or tonic-clonic, right?
tonic-clonic.
Petit mal.
Or petite, or that's just very those mild, maybe blank stares things. Absolutely. So what instructions are you going to be given to the parents or to send them home? Now, seizures are scary. The whole thing with seizures, if they're having seizures, there's nothing you can do. Now, some of these febrile seizures you can't prevent. It's 20 minutes later, all of a sudden they have a fever. You can be all the time with a thermometer, but then they have it. So it's telling them, put them on their side. Many of them will vomit. You don't want them to aspirate it. Protect from injury. Make sure there's nothing around them they can hurt themselves on. And then try to time it. Try to look at the way it happened. Today, thank goodness we've got our phones. Video it. You could show the doctor exactly what happened. Sometimes that can help in the diagnosis and what to do. So cerebral palsy, they're all different. There's mild to severe. Sometimes it is intellectual and sometimes it's developmental. You know, sometimes it's a combination of both. Now, when do we suspect it? Well, we're doing all of these growth and development and all of these milestone checkups, how they're turning over, lifting their head, how they're eating, gaining weight, all that stuff, right? Well, we're starting to see milestones not being met. And the first one would be not lifting a head up by 3 months, right? Something is going on. And looking at, let's say they are having seizures but they're not having fevers at all. That's going to be a flag to, you know, maybe cerebral palsy could be a part of it. So cognitive impairment, what is that? Well, it's you can't think and you can't express and you can't do. Your mind and your body don't work together. They sometimes inside they can think, these children, but they can't express it or they can't do it, okay? And they can't think the process out. They get confused. And this is a cognitive impairment. Think about the way they think. Intellectual impairment. Well, intellectual impairment, it could be mild to severe, right? What they do is when they're looking at cerebral palsy, they're looking at that intellectual impairment. They're looking, and it's this checklist of stuff you check off. And it says if they have two of these problems, it's some sort of intellectual impairment and some sort of therapy, something needs done. They can't communicate, they can't take care of themselves. If they can't be around other people, if they don't follow directions, all of these things will lead them into something's going on. And when they find these things, it's all about early intervention, getting them to people who can understand and make them be more than what they are at the moment. I've seen children with CP that was quite severe, where they actually are nonverbal and they have been given speech, physical, and occupational therapy since they were babies. And they can express themselves and they can tell you what they need. And, my little Jonathan, I always talk about, he was 7, severe CP, spastic, nonverbal, but he would see me and smile from ear to ear, and his hands would go up. It's like, my nurse is here, and he knows I'm going to go give him a big hug and a kiss. I was watching him in speech therapy, learning shapes and learning numbers and colors. Years ago, they didn't do that. And that's through intensive Monday through Friday treatment, making sure that they're getting what they need. So parents need to be taught that they need to participate in this. It's not just the therapist that does this. Parents and siblings can help with it, right? And these children, they're not going to be perfect, but they're going to have things that they do really well. So concentrate on those strengths, not on their weaknesses, because they need that. They need that feeling of feeling good. Can you imagine always telling them, no, do it again. That's not good. You know what to do. Or, oh, you almost did it. Good job. Let's try again. There's a way in order to, talk to these kids. So here we are. A 6-year-old boy developed cerebral palsy from a near drowning 16 months ago. His parents would like to know what they should expect of the child regarding education and future. And why would a near drowning cause CP? What happens in drowning?
There's a lack of oxygen to
No
the brain.
oxygen to the
Right,
brain.
right. They become hypoxic, anoxic for a period of time, and the brain doesn't get it, and little pieces die. So you don't get it back, but you can make all the rest of the brain work for you, right? So what would you expect? There is no limitation on these children. These children are doing more than they've ever done before because of the way that we are teaching them, putting them in school. Just because they have CP, does it mean maybe they have the movements and maybe they have a difficulty talking, but does it mean that their brains aren't normal and they can't go into normal schools? Yes, they can. So we don't need to limit them. They need to be pushed to be more than what they are today. And that's what cerebral palsy is about. It's not accepting, well, they're not going to ever do anything, then that they won't do anything, right? Give them that opportunity. So head injuries, well, major cause of death in children older than 1 year of age. Well, what do I call my toddlers? They're the dive bomb kids, right? They like to jump off couches to sofas. They want to be on the, end table and climb over there and climb up things, and they're falling and they get head injuries. I've seen toddlers climb up the front of a chest of drawers to get to the television, and it fell over, and the television smashed his head. Again, that one didn't make it. But head injuries are real with children. Concussions are when they hit their head. Maybe they're out playing and they fall down, they hit their head, or go around a corner and run into something. It's temporary. Remember, sometimes they go unconscious, or sometimes they don't. But usually there's a little bit of amnesia or memory, little fuzziness per se after it. That's normal after a concussion. So, and children with head injuries usually will have vomiting. That little bit of pressure in the brain causes vomiting, and that's the difference between adults and children. A child will vomit with that head injury. Shaken baby syndrome, yeah, this is abuse. These are when the children usually, and I've seen one case, not only were they shaken, they were smashed against the surround in a bathtub, and the brain was broken, had a concussion, and the brain was shooken so hard. These children could have permanent brain injury, and because of the swelling, they also could die. What do you usually see with this? Well, you have an infant who's fussy, 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 and never wants to do anything or cry, cry, cry. That's an infant, what you might see. Older kids complaining of the headache, dizzy, or can't see good, vomiting, again, is a telltale sign of a head injury. And then it could be trouble with breathing because it goes into those areas too. It's not something you want to see. But as a nurse, remember, our job is to try to take care of this kid. So if we think this is happening, it's something that we need to talk about, tell the physician, tell the charge nurse, so that we could get proper people there. So a 7-month-old is brought into the ER. The boyfriend was babysitting, and the baby's irritable. The nurse overhears a physician say he suspects shaken baby syndrome. So, what are those things that you would see as shaken baby syndrome? Told you right here, right? Irritable, irritable. If they were just shaken and not hit, you wouldn't see like a physical outside, right? But these kids, maybe they'll start vomiting too. So, there's little telltale signs. So, a brain injured child. The thing about a child who has an injury to the brain, they no longer can express themselves. They can't communicate. Some of them, they do have an understanding in there, but they can't put it to the lips, right? So you have somebody trapped, if you can think of those things. So one of the things that we try with brain injury children is to try to give them a method to communicate. We try to promote normal growth, normal development, and again, putting them in therapy, the speech, the physical, the occupational therapy. And these kids, we can get them back further than we thought many years ago. So, neurological monitoring of infants and children. Well, infants, the one thing I always look at, fontanelle. That fontanelle is a great thing because you see it bulging, we have a problem, right? That's a telltale sign. I mean, if it's sunken, we're dehydrated, but those big round ones, we know something. And of course, if they're not responding to pain, they're not alert, they're just posturing, which means they're arching their back. Pupils are very important, right? Scalp veins, they usually have those veins on the sides of their heads, the one in the front. They will bulge because now the inside is also swelling outwards, right? And then we're going to see the limbs aren't moving right. And then of course, when you have the moroatonic, they have those reflex sort of things going on. So very subtly, they can tell you something's happening. Now, near drownings, talked about it a little bit earlier, but near drownings there is a hypoxic anoxic episode. The thing with drownings, these children, they'll call 911, they'll get them out of the pool, and by the time 911 comes, they are awake and alert and running around, many of them. And the parents are like, oh, it's okay, they're fine. No, they're not. They actually can have problems of acute respiratory distress syndrome up to 3 days later. So these kids are hospitalized for 3 days to watch them. And that's when their lungs just shut down. Their lungs have been shocked. And the lungs all of a sudden go, I don't want to do it anymore. And it's because of the hypoxemia, could be the hypothermia too, but it's lack of oxygen to the tissue. And the lung doesn't like it. So we'd be monitoring their O2 saturations and respirations. So musculoskeletal. So children, you know, the bones aren't ossified. They're not that really hard yet. We know that there's little openings between that are going to be growing. We know that they heal quicker than they do with adults. Infants, 2 to 3 weeks they can heal, up to 4 weeks for young children, and then me, probably 3 months. And that's the way that the bones heal, okay? So muscles, and what do? They move the bones. So we know that if the muscles are good, the bones are going to work together, and these kids are going to be able to move along, and they're going to be able to grow and stand up and lift their heads, and they're going to roll over. We know muscles are working and bones are working when they're meeting those growth milestones, right? When you have an issue, when you're concerned for whatever reason, the first thing you're going to do, of course, is let's just look. Let's say they fell down and they hurt their arm, right? First, we look. Can they move it? What's the pain level? Then we're going to do an x-ray. When the x-ray is not showing you something, maybe CTs, MRIs, ultrasounds, or bone scans, all of those could be looked at. Sometimes bone pain, muscular pain, it's not an injury related. It could be due to other stuff. Well, think about me with rheumatoid arthritis. I've got pains in my bones, but it's the joints that are being attacked that create that pain. How would you know the difference? Blood tests. And here we go. That CBC, usually you'll see an elevated white count when you have that inflammation. ECASR, a sedimentation rate. That's inflammation. Do we have inflammation going on here? And then the HLA, again, looking for another answer to bone pain. So treatment could be a lot of different things. It could be arthroscopies. How about the knees, right? The meniscus goes, the bones, we could go in there and look. Biopsies, we do have bone cancers. Putting them in all sorts of traction, Buck's traction, Russell's traction, cervical traction, and then putting them in a cast or a splint. Now a kid falls down and they sprain their ankle. What should you do? It's as simple as have them lay down, get ice on it, elevate it, and wrap it up with an ace bandage. And it's called rice. So a fracture. Kids are always falling off of, the jungle gym, right? Off the slides. There always something going on with them. What do you see? Like I said, if they fell down, they hurt their wrist, they're going to might be swelling, might be discoloration, decreased movement. They can't move it. Sometimes numbness of the fingers, right? As I said, fractures in kids heal really quick. Adults, not as much. One of the things that we have to worry about is when we look at the growth plate, which is the epiphyseus. This is a place where the bone grows as a child grows. So we have to be very careful with those fractures, making sure they're set straight so you don't have a crooked leg or a crooked finger or a crooked arm. These are your type of fractures. Pathological is a bone cancer, right? It goes down the bone, across the bone, green stick bone. You know, there's all different sorts of fractures. So green stick, again, one side is broke, the other isn't it? Compound, it's broken. And a problem with it is the skin has been gone through. So you worry about infection. So infection and putting that bone straight. Simple fracture, usually what we see in kids, and we just need to straighten it up, put a cast on it. The oblique one is an angle at the end, you know, it's not straight across. And the spiral fracture, this is one that you really need to be aware of. This is when they take a kid and twist their arm really hard, usually in child abuse. They grab them like, and that causes those bones to break in a spiral fracture. So the types of traction. Now, Brian's traction is the top one. That's trying to get the hips back where they need to go. You have to be younger than 2, and you have to be less than 30 pounds, 20 to 30 pounds. And what they do is you're at a right angle and you pull your legs up, and it's trying to push that, usually the hips in, or it's a fractured femur they're trying to keep straight. And it works really, really well. Buck's traction is usually older kids that, again, fractured femur, and you need to pull those bones out together. The thing with Buck's traction, it must be free. You can't have your heel against the end of the bed. Has to be the weight hanging freely, and always leave the traction on. And then Russell traction is like Buck's, but it just has an extra piece just to hold that fracture in place. They're all used regularly in children. Cast and splints, you know, it used to be years ago, all they did was put cast on brakes. Today, they're a lot more, even with sprains, they're putting casts just to keep that leg good. Know that with cast and splints, when you put them on, you always have to worry about skin integrity. Nothing inside the cast, right? No hangers and pencils. And making sure the neurovascular signs are good. Compartmental syndrome can cause cause the loss of toes, of a leg, an arm, fingers. So again, making sure that they don't have any decrease in sensation in the hands, the feet, or the color is good, pulse if you see it, because dangerous things really can occur. When we put them on a cast, keep that leg elevated, again, doing those neurovascular signs, and teaching that child, especially if they have to use crutches. Kids want to like go running all over the place with crutches. And what happens? They fall forward and now they broke their nose. So we need to tell them how to relax, how just to do that, you know, 3 stand, you know, and to get around easily. And also telling the kids about if it feels way too tight, they can't move their little toes. Something's going on, you know, and to tell mommy when it starts to occur. These are the 5 things we look for when we're looking for those neurovascular signs, what we teach parents and the children. If it's increasing in pain, something's going on. If, you know, you have a pulse there and it's gone away, something's wrong. Again, this could be it. A cast needs to be removed. If the color is now white and it was pink, something's going on. When you're feeling numbness or you can't move, again, those things need immediate attention. They need to go either back to the ER or to the doctor who put that cast on. Now, osteomyelitis happens when bones come through the skin, or sometimes when foreign bodies get into the skin and lodge on the bone and causes the bone to get an infection. We see this a lot of times on the bottom of the foot. I'll see osteomyelitis, or of course, when it was a fracture that was open. So you have a nurse jogging on a trail. Suddenly, a 10-year-old boy swerves his bicycle around her, loses control of the bike, and falls 8 feet in front of her. Initially, he denies sustaining injury, but the nurse noticed that he limps slightly when he goes to retrieve his bike. How should you handle that? The kid is limping. What would you do?
I would have the child sit down first to prevent any extra injuries that could occur if it's not completely broken.
Right. Look at the area too. You might see bruising or you might see disfiguration. Are they moving the toes if it's the limp, right? Moving the toes. Do they have pulses? Looking for circulation. All of those things. A lot of things to look at once, but it's better to stop them. Then you could get help, or maybe you have to, it's a 10-year-old boy, it's not going to be easy to carry, but get somebody to help. Get them out instead of putting him back on a bike and causing more damage. Very good. So some of the neuromuscular things. Now, Duchenne muscular dystrophy is the most common of all of them, and it's the most common that you'll be tested on. And it's usually boys, ages somewhere between 2 to 6. And usually these kids grow, they're usually a little cognitive delayed, absolutely. But they'll get up and they'll be walking. You're going to see the calf muscles hypertrophic, means really thickened, big calf muscles. And they'll be walking, and now all of a sudden they're on their toes, they're falling, they're starting to waddle. And now you can't get up. So now they're walking up their legs to stand up. These things are giving you clues that something is going on here. So what do we do? Now, you've got a cognitive delay, you've got a boy, you see these hypertrophic muscles, you see him falling, waddling, something's happening. Well, what they're going to do is they're going to be doing what we call a muscle biopsy. We're going to look at those muscles. We're going to look at the CPK levels. CPK measures muscle degeneration. It's something that measures muscle activity. So that's why we do that one. There's also called an electromyogram that we do, and it puts shoots of little electricity through either probes or little needles in the arms, the legs, wherever, and we see does the muscle respond to it. Now, one of the things about doing this myelogram, this myelography, EMG, when they're done, they have made all the muscles move like they worked out. Sometimes they hurt when they come back, and it's normal. Just to tell them that we'll give them some Tylenol. One of the things about this muscular dystrophy, it's progressive. They'll end up in wheelchairs. Usually by their teenagers, their heart muscle and their lung muscle, diaphragm, stop working, and they usually die from that. Slipped femoral capital epiphysis. This is also called coxa and this is when the bone, the insertion just moves out of place. This, all of a sudden, you'll see a kid start limping and complaining of pain. And that usually will, key the parent to go look, and they do an x-ray and they find it. So what is our treatment? Well, this is one that will put them on Buck's traction, and it will rest it. They can't move, right? They're in bed, it pulls it, and it relaxes the tendons and muscles, and it will go back into place. Sometimes, if it doesn't, they'll do surgical, but usually the Buck's traction will work. Now, leg calf first disease, or coxaplana is an aseptic type of lack of blood supply in the head of the femur. So it's not an infection. The blood supply just slows down and again disrupts the head of the femur. That's why they're very similar in their names. And the treatment is really the same. And again, you'll see them start to limp. Something's going on. They do the x-ray. They see the haziness around the femoral head and they go, okay, buccal traction, and they're going to rest. And usually, again, it will go away. Now, I did tell you that there is a bone cancer, right? Well, there's something called an osteosarcoma, and it's usually children 10 to 15. They said sometimes it's due to other cancers, sometimes it's not. But what happens is it usually will go on the long bones, like the femur. If they find an osteosarcoma on the femur, they have to remove all of the femur bone. They can't just take it off, which means there's nothing between the knee to the hip, right? So what they do now is take the lower leg and connect it up into the hip. And why do they do that? There's a place to put a prosthesis so they're able to be mobile. Pretty crazy, isn't it? It's called salvaging the limb. And if you look at the picture, they put it on backwards so the prosthesis will fit right in there. And with osteosarcoma and, of course, cancers, you're going to always check for metastasis. Now, Ewing sarcoma, again, is a bone cancer. I've seen them on scapulas, on the bone, sometimes in the jaw. Usually, by the time we find them, metastases are there. So usually, it's not a good prognosis. So we usually already see it in the lungs. So Ewing sarcoma, again, it's a bone cancer. JIA, juvenile idiopathic arthritis. Again, this is another one where you might see disfiguring of the hands and whatnot, but usually what will bring this kid in and they'll diagnose this is that they start complaining in the morning or when they sit a long time. When they get up, they're stiff and they hurt. And then they start moving and they feel better. But then they see the swelling of the joints going on. Very, very difficult to diagnose. I mean, I have, RA, and it took them almost 10 years to finally diagnose me because there's not really specific tests. They kept saying you're fibromyalgia. I'm like, no, I'm not. And finally, after my fifth rheumatologist, they did this one test, and it was so off the wall. He goes, yeah, you do have RA. I said, yes, I did tell you. So RA, what does it mean for a kid? Kid in the morning is stiff. Once they get up, they get moving. They're much better. NSAIDs are the drug of choice for pain and exercise. Swimming is a great one for this one. And again, there's all sorts of medications. It might start out with steroids for just that, rough part, and it goes all the way up into biologics and infusions or whatever. But once you have JIA, you have it. It's not something that goes away. It can be systemic. It can be in one joint, or it can be in many, and that's subcurricular. So there's 3 different types. Many kids have torticollis. I know my last granddaughter had torticollis that came out, and she had a crooked neck, probably from the birth. It's usually when we see it. And it's basically the neck, it's stuck to the side, and you treat it by exercise, physical therapy. And with time, it works out and they're fine. Scoliosis. We usually see this about that pre-adolescent, adolescent age where they're growing a lot at that 12 to 14 age there. And you'll see an S-shaped curvature of the spine. How do we treat it? Well, if it's posture, we'll correct the posture. But if it's that structural S-shaped spine, we're going to put them on physical therapy and we're going to put them in a brace 23 hours a day. And with that exercise and brace, we can get them not perfect straight, but a lot better. So a mother gets a call from a 12-year-old daughter school nurse. The nurse informs the daughter has scoliosis, which was detected during a routine testing. The mother has never heard of scoliosis and is concerned her daughter's going to be crippled for life. What should the nurse say? Can you imagine some nurse calling you, oh, your daughter has scoliosis? What is that, right? It sounds like, something horrible. It's a curved spine. It's common in, if they're just finding it at 12, which is right where they start that growth, it's probably just physical therapy and a brace, and we can get these kids going straight up, and looking more normal. My daughter's best friend went through scoliosis and the bracing, and, she's pretty straight up today. Sports injuries. Kids love to play, right? They love to win. They love competition. It's just part of who they are. We know what happens with sports. Well, they can bump their heads. They can slide and get all of these abrasions and cuts and knees. They can sprain ankles, muscle cramps, shin splints when they're running too much. It's all just part of children and because of competition, and they want to win. They want to do. Now, we're going to talk about neglect, abuse, maltreatment, and it's in all classes of people, not the rich, not the poor, not the homeless, all of them. That affects everybody. Why it happens? Well, that's another story, but what do we do as nurses? What is our thing? Well, what can cause child abuse? Well, if you're sometimes it's the poverty, unemployment, or a dysfunctional family. Dysfunctional family could be a rich family. So I'm saying it could be both ends of the spectrum. What about a child who's disabled or temperamental, ADHD, hyperactive, or maybe it's a foster or stepchild? What if the parent was abused as a child? That's all they know, right? Or maybe that's that low self-esteem. They're taking it out on somebody else. They're overworked, overwhelmed. They're educated. And we know abuse does occur if there's substance abuse. It's just part of that whole big scenario. And that trigger, they need to be disciplined. They're going to discipline a little bit too much, right? And then it's between the families, and again, substance abuse, and a lot of times it's money issues. So there's types of abuse. There's emotional, there is verbal, sexual, physical, and there are different things. Can you imagine if you're always told you're fat, you're ugly, and you're stupid? That's verbal abuse. And I've seen that. Emotional abuse. It's like when they just don't show you love or hug. Never been kissed or hugged by mom or dad. There is sexual abuse, whether it's from a parent, whether it's from a friend, whether it's from the next door neighbor. There is sexual abuse. Physical abuse, you're going to see something on the child. You might see, like I told you, that little baby's head was smashed in the shower, and we saw that big fractured skull and all that big ecchymotic area behind the ear. That was physical neglect and abuse. What if the kid doesn't get a home, doesn't get food? Those are physical abuse. If they don't have proper clothing to wear when it's cold, that's physical abuse. So And of course, we know it's the injury part of it. Our job as nurses is to notify someone when you suspect it. Tell the physician, tell the charge nurse, I think something's going on here. Because as nurses, it's not for you to go in there and yell at who you think might be doing that, is to protect the child. And that baby who came in with that fractured skull, I took care of the baby. I got them help. Okay. And it wasn't the mother who brought that child in. Yes. So again, anybody can report abuse. If you're in a hospital type setting, of course, go through the channels that you have there, and they will get the people here, whether it's the police, whether it's DCF, whoever it is. So when you have a child who might be abused, it's how do you work with them? Because they're afraid of everybody. You're an adult too. So always teach them how to cope, how to manage their feelings, get them in therapy, right? Somebody to talk to, and then make them feeling good about themselves again. It's never the child's fault. It's never the child's fault. Some cultural and medical issues, know that there are different ways of approaching medicine, and it's cultural. Know that there are some things, for instance, the Chinese like to take those cups and heat them and put them on the back and draw out toxins. And it could look like bruises up and down the back. Or they take coins, rub up and down it. There are some things, if you don't know what it is, ask, say, what is this? I don't understand what that is. Always then, when you find things out, document it for the next person. And then when, of course, if we're seeing the abuse, always make sure that we tell who we need to tell, and so that we get the agencies in that need to be. Any questions? A lot of different stuff today, all different, all over the place. So let's go ahead and do our cahoots, and we'll be done. Week 5. Wow. The nurse explains that Brian's traction is reserved for children who weigh less than how many pounds? And it's 20 to 30 pounds. So the upper limit is 30 pounds. If they need traction, if they're bigger than that, they would go over to Buck's traction, okay? Or Russell. A multi. What nursing interventions are important for a patient with hydrocephalus before surgery? Now, hydrocephalus is when they get water collecting on the brain. It doesn't drain. That's when you're going to see that fontanelle, big and bulgy, right? So you got this big, heavy head. Think about it that way. So we're going to make sure that we're going to move the head around, right? Because it's heavy. And of course, vital signs and neurological status. No, we're not going to do activity that kid head hurts. And we're not going to keep them flat. It's going to increase the pressure on the head. What intervention will the nurse caring for a child in buckskin traction implement? You've got a fractured femur. We got it put together. It's being pulled. It's a little rope with a pulley and a weight hanging down. And that pull must be maintained. So if this kid is sliding in bed and the foot's hitting the end, traction isn't occurring. They can't, because of the pain, pull themselves up. So pull them up for them. Usually we put a draw sheet to help them go up. What pain management would be the most appropriate for a child status post-fractured femur repair? We have mild to moderate, and then we have now severe. What would you use for severe? This is when you're going to use your opioids. This one you're going to use your morphine. Those other ones aren't good enough. This is right after a fractured femur. They have rammed a rod up the femur bone and has a surgical incision. It hurts. Opioids. What will the nurse include when caring for a child in buck traction? Well, we got to think. Buck traction is used for what? Usually it's used for something to do with the femur, usually fractured femur. So with this, we want to keep the weights on constantly, always hanging, never on the floor. We want to keep that child just elevated head slightly, not 90 degrees. It's not pulling, but we're going to be checking to make sure that that traction isn't hurting the skin and rubbing it. All right, skin integrity. And another thing I'll tell you, neurovascular signs of that foot. What is included in the definition of pain, according to the Academy of Pediatrics? You know, the one thing about children, remember, they never lie. If it's a 6, it's a 6. Ask an adult, we're always a 10, right? But a child always gives you exactly what they are. It is whatever they say it is. What statement by the mother indicates understanding how to administer oral antibiotics for otitis media? Excuse me. You need to give all the doses and until all it's done. Twice a day, 10 days, all of them. Don't stop before because you want to treat it because it affects your hearing if you don't get that infection out. Another multi. What is the best way for the nurse to communicate with a 10-year-old child who has hearing impairment? There was a whole slide on it that I talked about. Or a 10-year-old really understands. It's all of the above. Very good. And you don't try to over exaggerate what you're saying. Very short, quick sentences. What is the best way for the nurse to communicate with a 10-year-old who has a hearing impairment? Again, asked in a little bit different way, isn't it? And it's again, sit in front of them, short sentences. The nurse is reviewing the characteristics of Ewing sarcoma, which statement indicates understanding of this disease. Remember, we had osteosarcoma, then we had Ewing sarcoma. Osteosarcoma, we take the femur out and we salvage a leg. Ewing sarcoma, it is sensitive to radiation and chemotherapy, but many times there's metastasis on this one. So it needs to be treated as quick as it can be. What characteristic manifestation does a nurse caring for a child with Duchenne muscular dystrophy document? Duchenne muscular dystrophy. Remember, this is boys ages 2 to 7, and all of a sudden they're starting to waddle and fall down and got hypertrophic calves. But remember, they're cognitively delayed, so it's a little bit hard. Again, it's that falling down that starts to alert them. You know, he was walking and now he's 2 years old and all of a sudden he's starting to waddle and fall down again. That's the clue right there. The nurse is providing instructions on how to treat a sprained ankle. A statement that needs additional teaching, which isn't right. You don't put anything warm on a sprained ankle. It's going to dilate the vessels and it's going to be more swelling and it will hurt. Remember, rice, rest, ice, contain, and elevate. Very good. How is pain managed the most effective way? And it's always that low dose and around the clock, and you keep it going. It manages it. Trying to give them big doses, here and there, it doesn't handle it. You don't want the pain to get there again. So keep it low with low dose. How does Russell traction provide adequate skin traction? Remember, you have Bucks, which is the whole leg, and Russell has that little sling right there in the upper thigh. It's because it pulls it out and up and it will hold it straight. It's that 2 directions. What finding would the nurse assessing the neurovascular status of a child in Russell traction report immediately? Well, you got to think, why are they in Russell traction? Is that the fractured femur? What would be wrong? What do you got to report? Remember I said check neurovascular signs of these sort of tractions. Something's going on with capillary refill and color. The circulation has been occluded. There's a problem. Bluish coloration of skin, absent of pulses, decreased sensation, paresthesia, all those things. What intervention is appropriate for a nurse assessing a pre-adolescent child for scoliosis? This is actually a way the school nurse found out probably the child had scoliosis. And what they do is they bend them over and they look at the arm length and they look at the back to see if it's straight. One shoulder might be down when you have scoliosis. What nursing action will significantly decrease the risk of serious complications for a child in Bryant traction? As in, what should you be doing to prevent any problems for this child? Nursing care of. And you're going to be checking those neurovascular signs, right? That's your biggest concern with traction. That and making sure that the skin integrity is there also. Which intervention would be helpful in relieving morning discomfort associated with juvenile rheumatoid arthritis? Remember I told you one of the things with rheumatoid arthritis is when you wake up, your joints are stiff and you can't move. You really have to think, sit there, and wiggle around. So, moist heat packs upon awakening do help. That's for many people. Put ice bags on me, but most people are heat. What instruction would the nurse provide to an adolescent who's been fitted with a Milwaukee brace? That's the brace we use for scoliosis. So I said it's a brace. It's 23 hours a day. They take it off only for bathing. To prevent any skin rubbing, you put a t-shirt on underneath it to protect it. Usually just a cotton t-shirt so that it prevents that rubbing there. And for the sweating, that is the braces over the t-shirt 23 hours a day. Which observation makes the nurse consider the possibility of child abuse when a mother says her young child fell? Well, there are different colors of bruising that tells you how long the injury's been there. If you're seeing red, green, and yellow, some of them have been there for a week, which means there are other injuries. Kids get broken arms. Some are clumsier than others, and they could have bruises everywhere. Mothers are always anxious when their child is hurt, and they want them to be taken care of. Those bruises, that's very alarming. On entering the room of a child in buck traction, which observation requires a nursing intervention? If the heels are against the end of the bed, is that child getting the pull from the traction? No, that's when you need to pull them back up with a draw sheet, right? So that they get the pull there. And that should be hanging freely. What type of fracture would be the most likely to alert the nurse for the possibility of physical abuse? Remember that scratch, the one that they take the arm, right? What is that called? It's called a spiral fracture. Should know that one. I'll tell you. What factor may trigger abuse in a parent? was reading you all of those lists of things on that one slide. So it's low self-esteem, and it's not knowledge deficit. It's other things like if they were abused as a child, substance abuse, they're feeling overwhelmed, financial problems. All of those things create all of this, craziness in a parent. They can't handle it all. Sometimes the kid gets it taken out on them. What assessment made by the school nurse would lead to the suspicion of strabismus? We have amblyopia, strabismus, and nystagmus. So remember, the eyes aren't working together. They don't focus. You cover one and they could see it clearly. Together, it's a big blur. What might the nurse explain is a common treatment for amblyopia? The other name for amblyopia is a lazy eye. And all we do is patch the good eye, make that bad eye work so we get that muscle strengthened up. What assessment does the school nurse recognize as a cardinal sign of hyphema? Remember, I showed you the picture. And that's that dark red spot that we saw on the bottom of that eye. That is hyphema. What type of fracture is an incomplete fracture where one side of the bone is bent and the other is broken? And all of these things are also on your exam review too. It's called green stick, okay? Oblique is when it's cracked to the side. What does the nurse explain to parents of a child with febrile seizures? One of the biggest questions the nurse asks is, so does it mean that my child is epilepsy? And the answer is no. Because febrile seizure is because when the temperature rises quick, it's called the rate of rise. And also, when you talk about epilepsy, it's different. Multiple times a day they have seizures, more frequent. Febrile seizures aren't. What type of fracture is associated with child abuse? And yes, it's spiral. Good. A multi? What factors may trigger a parent to abuse their children? All of the above. Yes, they are. Child experiences episodes where he appears to be staring into space. What type of seizure is that called? And it's called an absent seizure, exactly the call of it. You know, some say petit mal, but absent is more descriptive of a blank stare. What is an appropriate nursing action when a child has experienced a generalized tonic-clonic seizure? What are you going to do? Walk in a room, kid's having a seizure. Grand mal. Tonic-clonic. Arms and legs going. So remember, like we taught the child with any sort of seizure, it's always safety, safety, safety. Turn them on their side. Get everything out of the area that can hurt them, right? And be prepared if they vomit, you can suction that up too. Never put anything in their mouth. If they're out of bed, you're gonna just put them down on the floor. If you can put something underneath their head so they don't bang it, but usually just leave them where they are because they get so stiff you can break bones and break teeth. The legs of a child with CP cross involuntarily and exhibits jerky movements with his arms. What type of cerebral palsy is this? This again is on your study guide too. And it's called spastic cerebral palsy. They can't control it. It's just their muscles go tight. Which assessment finding in a child with meningitis should be reported immediately? And it's the blood pressure, because when you're seeing the blood pressure drop, this kid could be going into a septic shock. So that's something you should report immediately. We might need to start an IV, etc. Watch them closer. Which nursing assessment suggests that a child has a concussion after a child fell and hit the head on the ground? What did I tell you if they hit their head, had concussion? I can't tell you how many kids would slide into third base and hit the knee of the defender and have a concussion and be knocked out. Come into the ER and have no clue. Was I safe? Did we win the game? It's what you call amnesia, right? Can't remember what happened. It's not the other, it's all of that amnesia type thing. A 6-month-old child gets inoculated with Haemophilus influenza type B. What does this immunization protect against? And it's a viral. Haemophilus influenza is a viral. It's virus, which is influenza. The other one are all bacterial. That's the difference there, if you looked at them. Signs of increased intracranial pressure in a 3-year-old include what? Again, remember, headache, lethargy, vomiting, anything increased intracranial pressure in children. The priority nursing intervention when administering Dilantin to a patient diagnosed with epilepsy is. So you're giving kid phenytoin, Dilantin, they have epilepsy. What's some of your nursing care? What are you concerned about? What do you know about phenytoin from pharmacology? It causes hyperplasia gingivitis, big, thick gums. They need meticulous dental mouth care. Their gums get big. They get acne. They get hair. that's unusual. Young children. So it's mouth care. Phenytoin, mouth care. A practice that has been helpful in preventing intellectual disability is and we are now doing so many blood tests to figure out what's going on. And again, we catch them early. We can catch kids up. Kids are extremely resilient as long as we know what we're dealing with, and the sooner the possible. Which type of seizure presents with jerky movements upon wakening, following by collapsing? And it's called an atonic seizure. A sudden cry following by jerking and then relaxation is a typical type of what seizure? And that's called a general seizure. Bunch of different types and definitions here. This seizure is classified by a blank stare followed by rapid blinking, chewing movement where awareness returns quickly. What is that? And that again is that absent seizure, right? Isn't that the blank stare? Absent seizure. They added the other stuff, but still it's the blank stare, absent seizure. Jerking of one arm progressing into generalized jerking where the patient remains aware. It's what type of seizure? And that's called your simple partial seizure because we started in one place. So it's a partial, it's not generalized. Which diagnosis increased the risk of Rey syndrome in conjunction with the aspirin administration in the pediatric patient? And it's varicella. So chicken pox and aspirin should not be put together. Which is considered a manifestation of a retinoblastoma. So the retina is the eye. And it's that yellow white reflex, cat eye reflex. That's what you see with retinoblastoma. I saw one 8-month-old who had it. The presence of blood in the anterior chamber of the eye is called. We already had one question close to this. And that's the hypema. Very good. I'm multi. Which signs and symptoms are characteristics of brain tumors in children? Select all you like. So vomiting, again, all that pressure, seizures, absolutely all that extra pressure into the head, right? And headache upon awakening. And sometimes it gets to the headache all the time, but upon awakening for sure. Decreased blood pressure, it's going to be elevated. It won't be decreased. A multi. What will the nurse include when performing cranial or neurological assessments? So which one of these are related to cranial or neurological assessments? So heart sounds and lung sounds aren't cranial or are not neurological, the rest are. So again, it's reading the question. Be careful when you have a question like that. Make sure you know what you're answering. Which is the most useful diagnostic procedure in diagnosing a seizure disorder? EEG, that's those little electrodes on the head, and it shows little activity and seizure activity. And it's right there, you can watch them having a seizure. Even if the child doesn't look like it, you can see their brains. The mother of a 3-year-old tells us concerned about her child's bow-legged appearance. What's the best response? Yep. So it's not uncommon for 3-year-olds to still have bow-legged looking. It's the problem if they're having trouble walking or running. If they're not, they're okay. We don't have to go to a specialist yet. It's normal sometimes. What is the most accurate diagnostic tool in diagnosing suspected osteomyelitis in the pediatric patient? Accurate diagnostic tool. I mean, we know osteomyelitis, you'll have fevers, you'll have pain and redness. We know an elevated white count. Yes, the x-ray might show it, but the bone scan is absolutely the most accurate because it uptakes in that inflammation area. Intentional omission of behavioral verbal actions that are necessary for development of a healthy esteem is what? Omission. Omission of verbal behavioral actions that are necessary for healthy esteem. As in emotional neglect, right? They're admitting it. They're not showing you, they're not touching you, they don't know it. It's emotional neglect. Multi. What are appropriate interventions when caring for a child in traction? So a trapeze is for your older kids. It's the little thing above, they can pull up and they can move in it. Younger kids, we're going to help them up. Absolutely neuro checks. Absolutely check the skin integrity. We're not going to have a liquid diet. We're going to make sure they have roughage in their meals, right? We're not going to immobilize another extremity. And no, they're not going to be upright 30 minutes a day. They're going to be in the traction 24 hours a day in bed. We don't remove the traction. A 14-year-old's been diagnosed with scoliosis with a curve of 30 degrees. What medical intervention is needed? Now, in scoliosis, they measure therapy by how severe the curve is, the S, because it sort of impedes upon the lungs. That spinal column pushes up into one of the lung cavities. When it is more than 45 degrees, we do surgery. Under that, we're going to just put the brace and do therapy 23 hours a day. A 15-year-old has a left leg amputation after osteosarcoma and reports severe left foot pain. What should the nurse do? They've had a left leg amputation and their left foot hurts. So if they hurt, their nerves are still intact. Medicate them. And of course, give them support, but medicate them. It is real. It's phantom pain. It is real. Last question. What is the most important nursing intervention to identify and minimize compartment syndrome? So compartment syndrome means there's no blood flow and the skin dies, the tissue dies. Do those neurovascular checks and you will prevent it. Very good. Number 3, Moy. Or is that moi? Number 2, Brandy. Good job, Brandy. Number 1.
I was in 5th place. Oh.
AA. Number 4, MM and Cedar. It was a hard one, a lot of information. It was a longer cahoots, but it really, really covered those concepts that you're going to see in the exam. So it was a really good one. So that's all I have for today. Anybody have any questions, need anything?
Don't forget to add the math.
Oh, absolutely. Don't worry, I just thought about that myself. I got a new one for you. I will add it. Have a good weekend, guys. If you need anything, let me know. I'll see you next week for the exam.
Thank you.
Thank you.